Okay, I will share my screen. It will be the easiest. Just a second, I'm sorry for delay. So this should be it.
Okay.
Can you see the presentation?
Yes.
Okay,
Yes.
so thank you. My talk will be about the complex way how to do bariatric surgery, because there recently has been a really big data about immense effect on metabolic syndrome. And however, there is a big variation between the effect of the procedures. They vary, and mainly the main difference is in the long-term effect of those. So the most common procedure is still worldwide sleeve gastrectomy. However, only about 35% of patients have long-term efficient weight loss in comparison with bypass procedures, which are about 65%. These are data from the recent Swedish study presented on IFSO. So, moreover, we need to be focused on the increasing amount of revisional surgeries which are about to come to our departments, and we should know that the bariatric patients usually not only need one procedure in their life. So these are data from my department. As you can see, we have started in 2020 because before that, I was working in other hospitals. So this is like from the start. We started in 2020. There was only one procedure. There was a COVID stop, and so on and so on. However, as you can see, there is a big amount of malabsorptive procedures, mainly OAGB. And also in time, there is a big increase in revisional surgeries. So if you keep that in mind, we need to think that even if we do the primary procedure, we need to be ready to do some conversion later and be focused on like getting us a better operation field in the future if we do the revisional surgery. In revisional surgeries, we also always do contrast studies to know the like shape of the stomach and so on. And in high BMI patients, approximately above 50, I would advocate for a two-step approach, like first sleeve and keeping in mind that the patient will still need a revisional surgery or conversion for bypass in the future. To do that, you need, of course, very experienced and focused team because some of these procedures might be risky and challenging. In our department, we use or try to do ERAS, and we also prefer opioid-free anesthesia. So we prefer malabsorptive procedures. OAGB is our focus. It has a bit shorter operation time and excellent metabolic effect. Its main disadvantage is biliary reflux. In case the patient preoperatively has GERD, we would prefer Roux-en-Y. And the main types of revisional procedures we perform are conversions from sleeves of OAGB to Roux-en-Y and band removals. In Czech Republic, there is also a specific procedure called gastric plication, which we usually switch for OHGB or UNY. So this is common. We just make some preoperative assessment. I don't think we need to lose time on that. And if we do surgery, all the patients who undertake the procedure in our department have informed consent with the possibility of the staged procedure, because we never know, in fact, how the liver looks like, if it's too big, whether are we able to get to the small curvature safely, whether are there some adhesions or any or abundant adipose tissue. So in this case, to make the procedure safer, we start with sleeve and then switch it later. We perform, all the patients get opioid-free anesthesia. We also do leak tests, which you can see in this video, to be sure that the anastomosis is not leaking. If there is any problem, we can do ICG to be sure that the blood supply is fine. This is a video from a conversion from plication to Roux-en-Y. And we also mandatorily control bleeding from the staple line with induced blood pressure by anesthesiologists to be sure that there is the oozing. We can put titanium clips to be sure that that there is no bleeding in case the patient gets increased blood pressure after the procedure. Yeah, and let me get back. We also always close mesenteric defects even in OHGB, which we think is a good prevention from internal hernia. This is schematics of one anastomosis gastric bypass. It's both restrictive and malabsorptive, has excellent effect. But its main disadvantage, as I said earlier, is biliary reflux. However, our data only show 5 patients who had that, which is about 8%, which is still good. We only had 1 anastomotic leak. And what we also see in those patients are anastomotic ulcers. However, we always were able to treat it conservatively or endoscopically. We never had to do any surgery. In case there is the biliary reflux, we opt the patient for conversion to Roux-en-Y. Then it's quite easy because we just cut off the biliopancreatic limb and perform anastomosis a bit distally. So this is schematics of the procedure. There is a pouch creation on the first 2 or 3 pictures, and then linear anastomosis on the dorsal part of the gastric pouch. And this is the construction we also put across the anastomosis nasogastric tube, and then just close the staple defect. And afterwards, we have already seen it. We do the leak test to be sure that there is no problem. If just small amount of tips, I also always firstly check the small intestine and divide the greater omentum to be sure that it is safe to do the pouch, because we don't want, or we want to avoid, like creating pouch and then have some problem with the small intestine. So if there is any problem, we just do sleeve. If we do the anastomosis, it is necessary to make sure that the staple lines are not too close to each other, like to the staple lines of the pouch, to avoid ischemia of the dorsal part of the anastomosis. Also, I prefer to do to start the anastomosis a bit orally to avoid like biliary reflux, but still we have about 8%, as you see. And I also fixed the efferent limb to the gastric remnants to avoid kinking of the efferent limb. In Royan-Bai, we sometimes have it as a primary procedure, mainly in patients in GERD, but most of our Royan-Bais are revisional because we just convert the OHGB due to biliary reflux. There is still some controversy whether to do linear or circular anastomosis. I think Dr. Paseka will talk about it later, but it is a little more challenging to do the circular one. It is, of course, difficult technique, but it's better for revisional surgeries. We close all the defects. We only have 15 patients now, but no anastomotic leak. And we had one laparoscopy due to intestinal injury, which was not spotted like during the original procedure. So this is schematics, or these are pictures from the circular anastomosis. The principle is that if you have linear anastomosis, there could be a big tension on the anastomosis because it only holds in one stitch, in the proximal one. But if you have circular, the tension is divided between all those clips, and but it takes a lot of time to do it, and the learning curve is quite long. So this is the schematics, and in case you have in case you have revisional surgery, you don't have, if you do some pouch resizing, you don't have to be afraid of crossing the staple lines, which is good, I think. So, and the last part is about sleeve. It's poorly restrictive procedure. It's a high pressure system because we leave inside the pylorus. So it could increase the intraluminal pressure and gastroesophageal reflux, but it's very efficient. We mainly use it in high BMI patients as a procedure of choice, and then we switch for bypass after they lose weight, approximately 1 year afterwards. We had some bleedings, but never leak, which is good. Our biggest BMI was 70.15, which was quite a challenge. So this is how we do sleeve. Well, just a short video. You'll see that there is only the already skeletized greater curvature. And here you can see we use 42 French bougie. We want to have some remnant or remaining stomach, and we don't like get too close to the bougie. So we also and always check even the dorsal part that there is no kinking afterwards, and we try to get the staple line very direct, which I think it's important to avoid some distension of the sleeve. So we do always give the patients PPIs for 3 months at least after the surgery. In case there is some sign of ulcer, we add sucralfate. We get those patients nutritional support, and we try to, all the patients are informed that in case they have any problem, they should come to us, because there are not that many departments in our country that do like the complex way of bariatric surgery. So all of them are informed to come back if they feel any problem. So, and just if the patient after some previous procedure gets weight regain, we immediately start about the conversion or about revisional surgery, because if the patient gets too high with his weight, he might have problem, and it might be very difficult to do the revisional surgery. So with my last slightly, I just want to thank to my team, very dedicated, and it would not be good if I don't mention them. Thank you very much.
Patient, of course, as Dr. Cagas mentioned, we don't perform it in smokers because duodenum is outside of the possible endoscopic control if duodenal ulcers tend to bleed in heavy smokers. We usually don't operate on heavy smokers, no sleeve or any other procedures, but if they are light smokers and then they fail to quit, we can inform them that with higher risk we can do the sleeve surgery but never ruin eye bypass. But if this is a heavy smoker, I don't even do the sleeve. Sleeve is easier because shorter operation time. It is good for patients with previous lower belly surgery because of some adhesions of thick major omentum sometimes are giving us a hard time in bypass patients. But also long-term reflux disease is a problem. And as Dr. Cagas mentioned, in BMI 50 plus, it's a good option as a first stage of two-stage procedure. Technical tips that we can share with you is that the small pouch is about 80 milliliters is a good thing. Short pouch too. We use blue cartridges, sometimes yellow. We suture to the posterior gastric wall, not to the anterior. We cut omentum to make sure that the anticolic anastomosis is without any tension. We construct usually biliary arm 75 centimeters and alimentary arm 150 centimeters. We don't measure the full length of the small intestine, and we meticulously close mesenterial and Peterson's defect to prevent internal hernia. In sleeve gastrectomy, we use first yellow cartridge and following blue cartridges if it's the primary procedure. We start 3 to 6 centimeters from pylorus. We don't overshoot any anastomosis. We use 36 bougie, sometimes 42, but 36 is usually enough. We do leak test only in doubt. If in doubt, unlike in bypass where we use leak test all the time, and we use no clips because we want to prevent any inconvenient situation in future when redo surgery can be met with. If you encounter the clip into the new staple line, it can lead to cracking the line. So what to do when things go wrong? It is important to share some bedding experience. So our experience is that if the procedure is done properly, patient is very fit. The second day, they're without any pain medication or only paracetamol, they can walk, they don't vomit. So if the patient is unfit, is vomiting, it is not psychiatric. It is usually a problem. Sometimes the colleagues, they don't do metabolic surgery. They try to say, oh, this is fat patient that is pretending condition. No, if the patient is unfit, especially if the patient is vomiting, has tachycardia, hypotension, then something definitely went wrong. So we can use bedside sono. However, in a very obese patient, it is very complicated. So we promptly do CT scan to check the bleedings or leaks, or in literature, it is even justified that you do immediate laparoscopy. You would simply bring them back to the OR if tachycardia occurs, but in our environment, CT is very easily reached. So we lose this 20 minutes to check what is possibly happening, if he's face bleeding or early leak or anything else. So leak or bleeding, if tackled fast enough, it is not a big problem. Big problem is chronic leak. So then you need to have a good gastroenterologist that will help you with stenting and draining chronic leak patients, because that is really a problem. I can share one of our cases. There was a man with sleeve gastrectomy, with BMI about 55, and he was unfit the next day, but not too badly. So we have performed the CT scan, and a radiologist said there is no leak, and there was a small hematoma or fluid collection here, but the leak has not been proved. But the patient was not fit, and but unfortunately we didn't need a revision that day, because we hoped that he will be fine. But then it was proved like this, and you see that there is an abscess with a post contrast a positive membrane. So he underwent some surgeries. It was leaking again, and finally he ended up with internal drains by gastroenterologist, and it was healing 3 months, and it was really hard time. And he ended up finally with a conversion to Roux-en-Y, and he's happy now. So in conclusion, for those who know the movie of Transporting, you know what I mean. Choose patient, choose procedure, choose technique, and change life. You can really find the patient that losing 70 kgs and completely changing their lives. So I think I'm a little bit too long in my time, so I will skip the video for the sake of time. Thank you for your attention.
Thank you, Dr. Thomas. Okay, and then we will go to the third topics about how to minimize the complication after sleeve gastrectomy by Dr. Kyung Won Seo. Am I correct? Sorry for the first pronunciation. Right now, Professor Yang is from the Department of Surgery, Kosin University College of Medicine. Now he was the professor, and he was interesting in bariatric and metabolic surgery, laparoscopic gastric surgery, cancer surgery, anti-reflux surgery, hernia surgery, inguinal and ventral hernia also. He was the internship resident and clinical fellow from the Kosin University, Busan, Korea, and also he was the established many publics about the bariatric metabolic surgery of GERD and gastric cancer. And his activity right now, he was the chairman, Continuing Education Committee, Korean Society for Metabolic and Bariatric Surgery also. And he was the director of the Multidisciplinary Committee, Korean Society for Surgical Metabolic and Nutrition, and a member of the Korea Surgical Society and Korean Gastric Cancer Association, also Korean Hernia Society. Welcome, Professor Kyung Won Seo.
Thank you, Chairman. My name is Kyung Won Seo from Korea. And can you share my screen? Could you see my slide?
Sorry, Dr. Seo, and I cannot see your slide.
could you give me a share light to share my screen?
Okay, and could you send your PowerPoint to my email address? Is that okay? And I will download your PowerPoint to share the screen.
Sorry, again?
Sorry, and what I mean is that you can send your PowerPoint to my email address so I can share with your PowerPoint slides.
Oh, my PowerPoint amount is very big size file, so maybe it may be difficult to transfer my file.
Professor, can you place the alternate plus S, alternate S,
Sorry?
alternate S from the keyboard? You put the alternate S. You can share the screen by you place the bottom alternate and S together.
So sorry, I mean that I want to share my screen. Screen
Okay,
share.
okay.
Yes, but
okay.
you can put at the keyboard alternate S and then we'll have you can share your screen.
My
Can you
screen.
do that? Or maybe you can move your cursor to the bottom line. Move your mouse to the bottom line and you will see
Yes.
the control. Yes, okay, good. You
Okay.
can see it already. Yes.
Can you see my slide?
Yes.
Okay.
Yes.
Okay, sorry, I'm not familiar Zoom system, so sorry again. And thank you, Chairman. Today I'm grateful and I'm very thank you for inviting me as a speaker to this webinar. What I'm going to tell you about my topic is to minimize complications after sleeve gastrectomy. And bariatric surgery is one of the most effective treatment options for severe type of obesity. Among the various procedures, and the sleeve gastrectomy is most frequently performed bariatric surgery in the worldwide. This is because it has a similar weight loss and comorbidity, and it has a lack of intestinal rearrangement and a more favorable safety profile. So two-thirds of bariatric surgery is sleeve gastrectomy now. And the potential people talking about the importance of staples, I can show you potential complications that occur after bariatric surgery. First one is leak from the staple line, and second one is stenosis, twist, and kinking and bleeding. Among them, the leakage and bleeding is a very important problem to manage the patient after bariatric surgery. The bleeding is occurs in 0 to 6% of cases after bariatric surgery. It is decided to according to the day of the occurrence of GI bleeding after surgery, acute, early, and late. The most common bleeding site is gastric or short gastric vessels during dissection of the greater curvature, and the most of the bleeding occur from the staple line. So the after bariatric surgery, vital signs should be monitored at all times after bariatric surgery. Sorry, the slide is broken, but I want to show my 7 patients of bleeding after bariatric surgery, and 2 of these patients required reoperations. So my 7 patients all is the male, and there is no significant difference according to the obesity level. In all cases where reoperations were performed, bleeding was confirmed in stapler site, and we treated using appropriate hemostasis method. Even in cases when no surgery was performed, the bleeding can be confirmed at staple line when checked CT. And I will show my experience of bleeding case after bariatric surgery. 42 male with so many comorbidities received the Roux gastric bypass. This is my short video, and we did the small gastric pouch formation, and then we make the gastrojejunostomy like this. And we can close the gastrojejunostomy site with a hand-sewn suture using V-lock, barbed suture. And his blood pressure dropped once or twice in the night and seemed to resolve after receiving fluid therapy. And he maintained no dangerous situation until morning. And in the morning, I checked his blood pressure low at around 110/80. No evidence of abdominal wall rigidity was observed. And when we check the CT scan, the blood collection is seen in the subhepatic and subsplenic area and the lateral gastric area. Although conservative treatment was possible, after the hematoma turned into the abscess, emergency surgery was decided, considering the possibility of a sleeve leakage on chronic phase. The purpose of this surgery was hematoma evacuation and staple line repair. This is video of the operations. We can see the so many hematoma near the operation site, and we aspirate all of the hematoma in the abdomen, and we irrigate the saline, and we can clean up the abdomen with the bleeding site. So, and we can check the bleeding point of the staple line here. And we use the suturing at the bleeding point like this. And suturing was performed and at the 3 or 4 point of the bleeding point, and we can make the complete bleeding control in this laparoscopy procedure. And through these scary cases, I learned so many things like this, and moreover, I think that ensuring secure staple line conformation is very, very important. And second, my topic is the leakage. The leakage after bariatric surgery is the worst complication that no surgeon want to face. Leakage from the sleeve gastrectomy occurs mainly at the upper end of the stapling and is accompanied in pressure inside the stomach, making it very difficult to treat. Leakage after bariatric surgery can occur at both the cutting surface and anastomosis site. In this situation, the stability of a stapler is considered more and more important. Based on the data from the American College of Surgeon Network program, the incidence of leakage after bypass and sleeve gastrectomy was reported under 1%. It is very fortunate that it is less than 1%. Although 1% may be a small number, it is difficult to patient and due to the nature of surgery for benign disease. It is also a painful time for the surgeon. This is my first leakage case. I will share with you what a difficult journey it is to encounter the weak patient. 41-year-old female patient visited my clinic for the bariatric surgery. She did not have diabetes and severe comorbidities. She received sleeve gastrectomy. And then on the fourth day after surgery, the patient complained of left shoulder pain, and the medical staff suspected a postoperative leakage. The leakage was not clearly visible in the CT scan and taken that day, the 4th days of surgery. On the 6th day of the surgery, the leakage was clearly visible on another CT scan, and the amount had increased. The leakage continued to be seen in the upper GI series 18 days after surgery. Even though upper GI was taken after endoscopic clipping, the leakage still persisted. Even though I tried various methods, I was in a situation where I couldn't find an answer. So now I have to use a stent. Unlike stent that are generally used for leakage after total gastrectomy for the gastric cancer, in this case, a long stent must be used from the esophagus past the pylorus. Fortunately, an experienced radiologist performs this procedure very well. And afterwards, the percutaneous drainage was inserted for 2 and 3 months, and the extraction was repeated when the amount of drainage is decreased. To make matters worse, stenosis developed at the site where the stent was placed. So balloon dilatation was performed in after postoperative 130 days. And afterward, the patient was believed to be doing well, but 15 months after the surgery, the patient again complained on the left shoulder pain and visited to the emergency room. A CT scan confirmed that the abscess has formed and developed into chronic leakage in the yellow circle. So, in the end, among various treatment methods, a solution was found that could be resolved without surgery. This video is an endoscopic septotomy performed by our center and was submitted to a Journal of Metabolic and Bariatric Surgery in official Journal of Korean Society of Metabolic and Bariatric Surgery. So you can see the abscess cavity here, and then gastric lumen was here, and we can see the septum between the abscess cavity and gastric lumen. So this procedure is the cutting the abscess lumen and the gastric cavity, and we open the one spaces in the gastric specimen. So this is a very simple and not complex procedure, and this is the concept of the endoscopic septotomy. Before an endoscopic septotomy, we can see the abscess and gastric lumen, but after endoscopic septotomy, we have the same spaces between two spaces. So the procedure was performed successfully, and no further chronic leakage was observed during subsequent following endoscopy. The problem was solved. In summary, the insert and remove the percutaneous drainage twice, and stent is left in place for 6 weeks and then removed. Still, the problem was not resolved, so it was finally resolved with septotomy after 1 year, over 1 year. The patient did not lose enough weight and stopped visiting the hospital out of a frustration with the medical staff. There are numerous intraoperative maneuvers in attempt to decrease the incidence of leakage were reported, such as oversewing the staple line and reinforcing the staple line with biologic or synthetic material, such as pivoting glue or other tissue sealant. But there is no high-level evidence to support the mandated use of any of above practice for the prevention of GI leakage after gastric bypass or sleeve gastrectomy. So I think that the proper and excellent stapler is the one of the most important solution to prevent so many complications after bariatric surgery. I have to say this is very important things to the success of gastric sleeve. We have to have 1 centimeters of distance from esophagus to the last stapling to prevent the most frequent leakage after sleeve gastrectomy, and we have to make the sufficient distance 2 or 3 centimeters of distance from angle of gastric angle to middle of a stapler to prevent twist or kinking. And the third one is we have to 4 centimeters of distance from pilot to the post stapler to make the safe gastric sleeve for them. And to make this procedure, we must have a safe stapler, and we can control the safely and comfortably. The Ezisurg endo-powered 60 stapler has 3 solutions for ideal control. The first one is enhanced safety. It has a one-touch firing, so it can do the minimal effort to require. The second one is economic operation. Economic operation and enhanced safety is the same. I think that this one is a very important one. The combination of 120-degree articulation angle and the shortened jaw length improves accessibility and maneuverability. And the other one is ergonomic designs, and the economic design is helpful to the surgeons to control the stapler very efficiently. Okay, and this stapler have a 120-degree articulation. It can be by the jaw length, shortened jaw length 20 millimeters shorter than the other competitors the devices. So we can do the very efficiently make the stapling like this. I will show my short sleeve gastrectomy. Could you show me? Could you see my video? Okay. And after clearing gastric contents and air, and we do the greater curvature clearing by the electrosurgical devices, and go to the esophageal gastric junction, and the posterior gastric dissection is very important to make the appropriate sleeve. So the stapling the behind the side is located here. So we have to make the posterior dissection sufficiently, and we have cautiously not to damage the esophagogastric junction. And if we make the damage and his angle, so the occurrence of gastric leakage after sleeve gastrectomy is higher. So this procedure is a posterior gastric dissection. And then we start the stapling. The first one is appropriate in green cartilage because the antrum is thicker than other side of the stomach. The second one is appropriate in blue, and we have to check the Fuji moving up and downward. And this is the third stapler. And second one, fourth one is this stapler, and the 5 or 6 stapler is sufficient to make the gastric sleeve. And to prevent staple line bleeding, we have to cautiously control the bleeding by electrocautery. And if you want to complete the bleeding control, we have to suture at the 1 or 2 point of the staple line here, like this. And we remove the gastric specimen, and I suture the lateral peritoneum and the post staple line to prevent gastric sleeve kinking or twisting. This is very helpful procedure. After sleeve gastrectomy, the staple line attached to the liver side, it may cause the gastric twisting. So we can prevent the kinking after sleeve gastrectomy. So this mechanism is caused by this easy endoflex have a 2 joint and 60-degree articulation. So it is very important mechanism. Thank you for your attention.
Thank you, Professor Kyo. And we move to the next section by Dr. Asadayus Nantha about the outcome of sleeve gastrectomy as the primary bariatric procedure. Professor Dr. Asadayus Nantha, right now he on the fellowship training MAS program in Hat Yai Hospital, and he working in the Tha Bo Krapin Hospital. Please welcome Dr. Asadayus Nantha.
Thank you, Chairman, for the interview. I will share my screen. Okay. Okay, first of all, I feel honored to be a part of the great meeting. And today I will present about the outcome of the sleeve gastrectomy as a primary bariatric procedure. I'm talking about the introduction of the bariatric and the surgical technique, and some result and conclusion. Sorry. This is the epidemiology of disease of the obesity in United States, and you can see the graph at the right side of the screen. You can see the graph show the obesity and the severe obesity, and the epidemiology of the obesity and rising every year. And you can see this graph. I'm focused on the graph in the 12 to 19 years old, and it increased every year since the 2000, and increased more than the other age group. These are the prevalence of the obesity in the Asia, like Thailand, Malaysia, Indonesia, China, South Korea, and another country in the Asia is increased every year also. And when I focus on the Southeast Asia, the Malaysia in the top of the prevalence in the Southeast Asia, about the 15%, and the lower prevalence of the obesity in the Vietnam and in the Asia, the Vietnam is the lowest prevalence of the obesity. And when focus on the childhood obesity, every year more than another age group. So in the next 10 years, the obesity patient in the will increase. By the prediction in 2013, the obesity patient will be the billion people in the world. And the complication, the serious complication in the obesity is a cardiovascular disease like a heart attack, myocardial infarction, and with another system like a stroke also. Had to show the complication in the other body system: neurological, psychological, cardiovascular, endocrine, gastrointestinal, pulmonary, renal, and musculoskeletal. We mentioned about the ghrelin hormone. Ghrelin hormone is the hunger hormone. They can produce by the leptin and can control the level of insulin that produce the pancreas, and the ghrelin can produce by the stomach and pancreas and adrenal as well. Ghrelin is called the function in the hunger hormone, and you see in the right graph, you can see that ghrelin level in the increase before the morning, before the lunch, and before the dinner. In this series, the indication for surgery is the patient have the BMI more than 37 or more than 32 with a significant obesity-related comorbidity like diabetes, hypertension, and dyslipidemia is uncontrolled. And age between 16 and 65 years. And a document of the failure of non-surgical approach to long-term lost weight more than 6 months, and other commitment between the multidisciplinary team and the patient and the doctor. The contraindication is the severe psychosis, severe mental retard, drug or alcohol abuse, and patient with the portal hypertension and the active cancer and the during pregnancy is the contraindication. And in this series, we use the orogastric. We use the 38 French bougie. And the post-operative, patient will start walk within the 8 to 12 hours after surgery. If patient start the surgery in the morning, so in the evening in the same day, patient should walk. And if patient finish the surgery in the evening, so patient should walk in the next morning and liquidate what start in the first day of operative. And the patient will discharge on the second or third day after surgery. The video shows the patient walk in the same day of the surgery. And the pot insertion, we use the 12mm pot and the left and right side and the central abdomen, and use the 5mm pot in the right upper and left upper abdomen. And I have the primary monitor in the left side of patient and the secondary monitor in the right side of the patient. The surgeon and the cameraman stand in the right side of patient, and the assist stand in the left side of the patient. We use the TOCA and in the more than the length is more than the normal TOCA, and I use the staple line and gastric staple and the vessel sealing. And this is some specimen from this series. And all patients will be treated by the multidisciplinary team like medicine, like the anesthesiology, like the nutrition and endocrine. It is characteristics and general data of the patient. The age, the mean 45 years old, and the gender, the female, more than the male. And the BMI, the mean is the 41.5. And the comorbidity, the most patient with the hypertension in the 78, and the diabetes in the 44, and the OSA or the obstructive sleep apnea with the CPAP in the 34 patient. The mean operating time in the 75, and the hospital stay in the about the 3.5 days. And the criteria for the diabetic remission, the first one in the fasting blood glucose. The partial remission in the patient after surgery have the fasting blood glucose 100 to 125 milligram per deciliter, and complete remission in the less than 100 milligram per deciliter. And about the hemoglobin A1C, the partial remission in the patient after surgery is the hemoglobin A1C 6 to 6.5%, and complete remission in the less than 6%. And the prolonged remission in the patient with diabetic after surgery don't need the anti-diabetic in the 5 years. This graph show the excess weight loss after surgery in 2 years. In the 5 months, 6 months, and the 9 months, you can see the graph is the very rising. So in the 5 months or in the 1 year after surgery, the excess weight loss very increasing, and you get the plateau phase in the about the 2 years after surgery. And this is show the BMI after surgery. In the initial of the BMI is the 41.5, and the mean of the BMI will decrease every 3 months, and get the plateau about the 2 years after surgery. This graph show the outcome of the comorbidity of the patient. The patient with the diabetes in the 44 is equal to 18%. No change in the 0, and the partial remission in the 30 patient, and the complete remission in the 14 patient. And the patient with the hypertension is the 78 patient. No change in the 7 patient. And the partial remission in the 47 patient, and the complete remission in the 24 patient. And about the dyslipidemia and the 54 patient, no change in the 1 patient, and the partial remission 47, and the complete remission in the 6 patient. And the patient with the asthma is a 6 patient in this series, and no change, and everyone improved. And the partial remission in the 5 patient, and the complete remission in 1 patient. And the patient with the sleep apnea, after surgery, every patient improved, and the partial remission in the 4 patient, and the complete remission in the 30 patient. And about the infertile, because the patient with the obesity have the high level of the estrogen. So patient with the obesity got the infertile condition. After surgery, the partial remission in the 3, and the complete remission in the 4 patient. And about the complication and the 0 mortality, staple lining in the 1 patient is 0.4%. And in this patient, and the leak and staple line, and we correct with the endoscopic by the endoscopic clipping and the endoscopic suture. And about the bleeding, and the 2 patient in the bleeding, and the wound infection in the 0, and the U-tongue bleeding in the 1 patient. This case in the I consult the urologist to cystoscope, and seen the bleeding in the urinary bladder, suspect from the trauma when the input the urinary catheter. And the 1 patient in the get a thrombosis. after 2 months after surgery. She come back again in the emergency room with the patient with the abdominal pain and the fever. He got a fever. So CT scan in the same admission. So the thrombosis and the portal vein, and resolved by the give the anticoagulant medicine like enoxaparin. It is some picture of the patient in this study, and have the 5 patient underwent to the abdominoplasty after surgery 2 years. The obesity is the chronic condition, and then had many cause of the obesity in the patient. And in the prediction in the 2013, 20% of the women and 14% of the men have got the obesity. The patient will increase to the 1 billion people in the world, and then living obesity globally. According to the new world obesity, and the obesity will be the main condition like diabetes, like cancer, like a trauma in the world. Thank you.
Thank you, Dr. Asadayus. We move to the next section for the concurrent cholecystectomy with bariatric surgery from Dr. Edwin See from Malaysia. Dr. Edwin See was right now he was a clinical specialist in the general surgery Queen Elizabeth Hospital in Kota Kinabalu, and consultant general surgeons Queen Elizabeth Hospital 2 in the Kota Kinabalu also. Please welcome Dr. Edwin See. Thank you.
Good evening. Can you all hear me?
Yes, I can hear you.
Can you hear me? Okay. Can you see the slides?
Yes, we see.
Okay, thank you. Good evening and good afternoon to all here in this webinar. I thank the organizer for giving me this opportunity to present on this topic, concurrent laparoscopic cholecystectomy with bariatric surgery. My apologies as my emphasis is not too much on bariatric surgery. As for the disclosure, I'd like to thank Ezisurg Medical for sponsoring this webinar. And in relation to this topic, I'm a general surgeon dealing with both gallstone disease and obesity in Queen Elizabeth II, a government hospital in Kota Kinabalu, and in treating this condition in Sabah in East Malaysia. Now, gallstone is common in about 10 to 20% of general population, and more so in the obese patient. Habit et al. Reported that 10 to 38% of patients undergoing bariatric surgery will develop gallstones following rapid weight loss in the 2 years after surgery. The mechanism that explains why patients after bariatric surgery are at risk of developing gallstones include an increase in biliary cholesterol concentration following the rapid weight loss, and this undissolved cholesterol is prone to crystallize into stones, especially in the presence of calcium and biliary mucin. There is also gallbladder hypomotility due to vagal nerve resection during the surgery and a decreased cholecystokinin secretion causing bowel stasis. Nearly 50% asymptomatic patients will develop symptoms related to gallstone and require cholecystectomy within 1 year after bariatric surgery. Now, there are two groups of view as to whether to perform cholecystectomy during bariatric surgery. The reasons to support this concurrent surgery are as the following. Post-bariatric patients are at risk of developing gallstones following excess weight loss, which can be symptomatic and cause further complications. There is difficulty in accessing the biliary tract with ERCP for CBD stones, which is more so in patients with root and wide gastric bypass. A number of evidence in literature available to support safety of concomitant surgery with no increase in the rate of major complications, except in surgical site infection and length of stay. Concomitant surgery has advantage on cost and resource utilization in the healthcare system in reducing the cost of a second operation or hospitalization from gallstone complications. And finally, this also eliminates additional workup for symptomatic gallstones in patients after their bariatric surgery. Now, the reasons that is against concurrent cholecystectomy during bariatric surgery are as below. Performing both procedures can increase the risk of post-operative complications and mortality, and also increase the time of anesthesia. There is difficulty in concurrent surgery so the suboptimal port placement, the visceral obesity, and the large liver that engulfs the gallbladder, thus making this a challenging operation. Most post-bariatric patients do not suffer from gallstone complications even in the presence of gallstones, and sometimes this can be treated non-operatively. Let us look at some evidence from the literature search. Aridi et al. In older times show that in sleeve gastrectomy and cholecystectomy, the operative time increased by 33 minutes, but there is no significant increase in mortality, hospital stay, and adverse events. However, there is a slight increase of bleeding and pneumonia in these patients undergoing concurrent cholecystectomy. Habib et al. Now reported in their study of 222 patients with asymptomatic gallstones randomized to sleeve gastrectomy with or without concomitant cholecystectomy. And they found that there is no difference in complication, for example, wound infection, bowel leakage, gastric leak, ileus, pneumonia, and bleeding. Again, the duration of surgery increased by 40 minutes, and the post-operative hospital stay were longer with concurrent laparoscopic cholecystectomy. Now, Dang and colleagues also did a review on cohort of nearly 6,000 patients with propensity match analysis using MBSA-QIP database, and found that there is a higher rate of cardiac events and acute renal failure with concurrent cholecystectomy. However, the rate of bleeding, leak, reoperation, readmission, and death was similar in both groups. The operative time was longer with concurrent cholecystectomy, on an average about 23 minutes. Now, according to this Amorin Cruz, who did a systemic review and meta-analysis of 50 patients and almost 65,000 patients in 2023, and they found that the risk of de novo post-bariatric gallstones disease was 20.7%, and the symptomatic gallstones was only 8.2% with a mean follow-up time of 29 months. Bariatric surgery with prophylactic cholecystectomy was associated with a higher post-operative major complications compared to bariatric surgery alone, with the odds ratio of 1.74. And while the mortality was similar between the two groups. And they come to the conclusion of this review that the risk of developing de novo symptomatic gallstones after bariatric surgery is not substantially high at only 8.2%, and severe biliary complications were even extremely rare. Patients who underwent prophylactic cholecystectomy had a longer operative time and a higher rate of post-operative complications than those who went through bariatric surgery alone. But again, the mortality and the hospital stay was similar. and thus they come to a conclusion that it is not justified to perform prophylactic cholecystectomy in patients without gallstones. Now, so far, the conclusion from guidelines or evidence as so far is that current guidelines do not recommend concomitant cholecystectomy for asymptomatic gallstones. Long-term follow-up studies have shown that the incidence of post-bariatric surgery symptomatic gallstones needing therapeutic cholecystectomy increased up to 40%. However, the available evidence so far is not sufficient to answer this dilemma. Further studies should evaluate how to treat patients with asymptomatic gallstones. Most studies found that concurrent cholecystectomy during bariatric surgery is safe and is recommended for individuals with symptomatic gallstone disease. The use of ursodeoxycholic acid is associated with a significant reduced risk of developing gallstones. Now coming to how concomitant cholecystectomy and why is it technically a challenging procedure. This is maybe due to the gallbladder position and is often embedded in a large stenotic liver, making a difficult view from the abdominal fat. And so there may be adhesions to adjacent visceral fat and a thickened gallbladder wall due to the previous cholecystitis. There may be inadequate position of the trocar and in which we will need additional ports. The surgeon and the assistant may be tired and it may prolong the surgery and anesthesia. And more morbidities will come from converting to an open surgery for a difficult cholecystectomy. Now there are mainly two approaches of how to do this cholecystectomy, and the most common will still be the conventional way of doing it, with the gallbladder being tracted up, the hepatocystic triangle dissection, the cystic artery and ducts will clip once the critical view of safety is achieved. The other way is the fundal or the Gleasonian approach, and this is basically for difficult calloid dissection or to see the calloid triangle, whereby the gallbladder is dissected from the fundus, from the liver fossa until the cystic artery and duct is ligated with the endoloop of clip. There are some tips and tricks as how to perform concurrent cholecystectomy. The additional parts for gallbladder retraction, either to push down the visceral fat or to the duodenum down, or to retract the gallbladder up. The use of the liver retractors to partly retract the right liver. If the gallbladder is very distended, can aspirate or decompress the gallbladder so that it's easier for retraction. There are times where the stone is impacted at the Hartmann's or cystic duct, and this can be dislodged to make the dissection easier. And finally, again, if the dissection is difficult, then the fundal approach is used until the Hartmann pouch or cystic duct is reached. Now, as for my practice, how I do my bariatric surgery, for my position, I will stand on the right side using the 5 mm and 12 mm port, and the camera can be placed on a umbilical side or a left supraumbilical region. And the assistant will be on the left side of the patient using a 5 mm port. Most of my bariatric surgery will be done in this way and not in a French position. After the bariatric surgery, when it comes to do the cholecystectomy, the surgeon will move to the left side and using this 12 mm, whereas the 5 mm port will be placed to replace the liver retractor. And the camera will be positioned using this 12 mm on the left side, and the assistant will be using this help to retraction using this 5 mm port. So this is a similar way of doing the conventional cholecystectomy. Now this video is to show the way of using this conventional type cholecystectomy. At times, I may use the liver retractor to help to partly retract the right lobe and the gallbladder. But this can be a bit difficult, and the retraction may not be useful, as you see that the lower part of the gallbladder is still have adhesions to the from the visceral fat, and thus I change it to a 5 mm port at the replacing the liver retractor port. And now using an energy device to release all the adhesions, and further retraction up of the gallbladder is made easier in this way. Okay. Now coming to the dissection of the hepatocystic or the Kellogg's triangle, as now you're still using the energy device and trying to clear off the visceral fat on the gallbladder, which is present more in the obese patient. The cystic lymph node is seen here and dissect medially, and near there will be the location, the cystic artery or the cystic duct. However, in this case, the cystic artery is not seen and most likely being cleared off using the energy device. And the hepatocystic triangle is further dissected, and the gallbladder is mobilized further anteriorly here, as can be seen, using the energy device, and then proceeding on with more mobilization in the posterior side. And once the critical critical view of safety is seen, use the hemolog through the 5 mm port. In this case, it appears that the cystic duct is kind of small, but however, checking through the dissection area, there's no other suspicious biliary duct seen, so it's quite convinced that this is the cystic duct. And the rest of the gallbladder dissection is as normal way. The other way as to how I approach my cholecystectomy is I still stand on the right side of the patient using this 5 mm and 12 mm port, whereas the camera and the assistant will continue on the left side. And it's quite similar in the bariatric surgery position. And here I'm operating on a patient with symptomatic gallstone where she has a previous acute cholecystitis, and that is the indication for her cholecystectomy. Now doing a laparoscopic sleeve gastrectomy in a similar way that was presented by the earlier presenters. And now this is the part, the full fundal mobilization, as this is important to completely remove the fundus during the sleeve gastrectomy. And here I'm using Ezisurg endo staplers, a manual firing handle. I'll start off with the green stapler, then followed by 2 yellow staplers, and then lastly the 2 blue staplers to complete the sleeve gastrectomy. Now coming to the gallbladder, as she has previous acute cholecystitis episode, so that makes the adhesions more, and the surgery may be more challenging, especially with a fatty liver. Again, the gallbladder is retracted up and all the adhesions are released using the energy device, and it's not easy to hold up this gallbladder. I will get my assistant to help to push down the duodenum and the omentum that's at times occluding the view, and then later on the assistant will retract the gallbladder upwards. And bear in mind, the surgeon is standing on the right side and the assistant on the left side. That means this is the different way of approaching this cholecystectomy. Now, further clearing off the visceral fat on the gallbladder anteriorly with this energy device, and be careful in using energy device, at times it may cause more injury that is not being seen. So the trick is to get a small bite. And also, there are times that bleeding is good to secure to stop all this bleeding, as blood may make the view not clear, and the cystic dark lymph node is seen, and again dissect, and to dissect it, to push it medially. I will usually keep the dissection near to the gallbladder. The hepatocystic triangle can't be seen clearly in an obese patient because the gallbladder is distended and the liver that is enlarged engulfs the gallbladder. So the view will be much more difficult. Therefore, the dissection has to be careful in clearing off all the fat. And now I'm clearing all more on the posterior view. Until then, I will use a Maryland to open up the hepatocystic triangle more instead of using the energy device. Okay, now you can see that this is a Maryland to dissect, to open up the structures that's near to the gallbladder. Again, the window opening can be small because the gallbladder is still positioned quite near to the liver bed. Opening up the window anteriorly and now posteriorly. As the window opening is small, I will continue to use the energy device to mobilize the gallbladder, and it's easier to mobilize here on the posterior aspect. Until the window at this hepatocystic triangle is much more obvious, and I can have this better critical view, safety view. Before I decided to put a hemolog plate using the 12 mm point, as this is a bigger size hemolog as compared to the first case. I do not routinely perform intraoperative cholangiogram as I have limited resources in my hospital and difficult to get this service during the operation, and it also increase the operation time. Just a short word about the role of ursodeoxycholic acid in post-bariatric surgery, and it's found that prophylactic use of UDCA is significantly decrease the formation of gallstones and symptomatic gallstone disease, and also decrease the rate of cholecystectomy. So it's recommended to give 500 to 600 milligrams of UDCA for 6 months post-bariatric surgery. However, there are studies to show the compliance with this medication is variable from 40 to 85%, and some may say that it's not justified to use after bariatric surgery. So in conclusion, current guidelines do not recommend concomitant cholecystectomy for asymptomatic gallstones during the bariatric surgery. However, concurrent cholecystectomy during bariatric surgery can be performed safely for individuals with symptomatic gallstones. With this, I thank you.
Thank you, Dr. Edwin See. Okay, so go to the last topic for today. Everyone is still there. Okay. Can you see in my screen?
Yeah, I can see your screen.
Okay. Again, thank you for the Ezisurg Medical to set up this webinar. This the Thailand, and this is my hospital, was in the south part of Thailand, and I do both the laparoscopic surgery and the endoscopic surgery also. And today I will talk about the tip and technique for the total fundectomy in the sleeve catectomy. We know as the ghrelin is the hunger hormone that the secret when the fundus is collapsed. And this is the most pathophysiology that make the people got a high weight. And the second one is the angulation of the antrum and the pylorus that make the fundus is dilate. Also, you can compare with the right side and the left side. Some of the patients maybe did not have the angle here, so the foods can go more easily, so make them every hungry oftenly. So the sleeve procedure can collect both sides, both this you can create the angle also. Okay, when we talk about the how far from the EGJ junction, there's many the paper, but the distance is around maybe 0.5 to 2 cm, or some is just 1 cm. Normally we accept right now in the 1 to 2 cm, not more than 2 cm. But in my personal, I think is the fundus is make more weight gain. If you cut here and you still have some angle, so it's make the patient got the weight gain again. So we try to do the remove all the fundus, because in my idea, I think if the failure to the treatment, I think it's from the surgical technique, not the patient fault. And the fundus, okay, also we want to keep it because we want to prevent leakage. And also that the also talk before the leakage from the sleeve, they're not more than 1%. But also we correct is very difficult. But it's how if the leakage will occur, I think it's the same like the PU perforation size. Because when if we do the PU perforation, also we have this data. Also we try to do the suture or non-suture. We can do the classical Graham fat or do the modified Graham fat also. We try to do the suturing. And then we put the omentum to patching also. So for this concept, for this concept, so try to start with same procedure at every one show. I try to put the 10 visiport by the right paramedian, pararectus, and the 10 pot again is the on the right pararectus, and the 5 on the right upper, and the left 5 pot on the left upper. And if it's difficult or the fundus is too high, we try to put another one in the more upper right pot. And we put the natasan in some cases if it's difficult. And we start to divide the gator curvature also by the energy device, also harmonics or anything else. And then we try to approach to the fundus as much as possible and try to identify the EGJ also. And we open the posterior gastric mobilization also. Like this one, try to open the fundus as much as possible that you can to make free fundus is free. I think this approach is the same as everyone do. Until the EGJ was identified, and then we do the gastrectomy by put the staple. Also, we can put it until everything is removed, and then we do the omentopexy from the last staple line that we put at the fundus that we sleep until, and then we try to suture as much as possible. The suture can fix also to make the stomach not twist, and also can stop the bleeding also. We try to suture just only push the omentum patch, not too tight too much, and not too deep to the stomach. We just put in the near the stapeli and make sure that the omentum is stay around there. And then we can lock the bark suture by put overward or put the hemlock clip also. And then the procedure was finished. The tip of this technique is to make sure that the fundus is free, and you can remove all the fundus also. This is another one for my fellow. You do the fundectomy also. You see, you cleanse also, the fundus is all removed out. And you will see to make sure that the cruise diaphragm is can identify. Sometimes we can open the esophageal ligament also, like this. And the second one is we must suture to make sure that the omentum will patching at the stapeli also, to make sure the leakage is not occur. The important stitch is the first stitch, because always the leakage is occur in the angle of his. And the borderline here, you will see the bleeding is came out, and the suture can collect it more easily. This one is a specimen. You will see the fundus is all came out. We always put the air in with the maximum pressure for the laparoscopic station and put the specimen in the water to make sure that the leakage will not occur by the staple. This is some of my patient. This guy is about 200 kilometers, and this she was about maybe I think 200 or so. Thank you, everybody. Okay, right now we move to the discussion. Is anyone has a question?
I have a question for you.
Yes.
Because I think some of you guys also does it. My question is about the omentum fixation to the staple line on the sleeve, because I used to do it, just to like avoid kinking. But when I did it in a patient who was 68 BMI after the surgery, then the weight of the omentum itself caused not kinking, but there was so sharp angle because of the weight of the omentum that it caused complete obstruction. So I had to like cancel the omentoplasty. So that's my question. Did you have any similar problems with it? Because after this experience, I quit doing this omentoplasty and started to do the clipping, you know.
Oh. No, I haven't seen this case before. I have no experience for that one. But
I think
okay.
sorry, can I have a short comment on this?
Okay.
I think the omentoplasty is not needed because there is a simple answer to it. When you go for the redo surgery, you always see attachments of the greater omentum to the staple line, so it always happens itself. So let's make the nature to do the work instead of us, and we don't add any extra risk with stitching and you know, causing an unnecessary bleeding or any other of unnecessary complication. And oversewing of the line has been proved to reduce some of the bleedings, but doesn't reduce the leakage.
I'm not the first time that I start, I will do the omentopexy or the line of the staple. But right now, sometimes leakage will occur in the upper side. So I try to do the just only 1 or 2 staple line from the esophagus that I think is enough to prevent the leakage also. Because I cut too close to the esophagus, so I think the leakage will maybe more than 1% that will occur if we leave if we don't do the omentopexy like this. But in the case that the Dr. Cagas, I don't have an experience with that one before.
In fact, the guy was 68 BMI. So the omentum itself had to weigh 10 kilos, I think. Yeah. So it was very, very big. I think to avoid leakage in the upper part, you don't need the omentopexy. But if you leave the dog ear big enough, because the principle of the leakage is because of the tension on the staplers on the upper part. So you need to leave some dog ear there, and with this the big bougie should help. You know, so we in fact use the 42 and make sure that we are pretty far enough from the bougie to be sure that there is no tension on the stapler in the upper part. So, and then I think it's not necessary to do the omentopexy, but you know, it's always about the experience of the surgeon, and if you have good results with it, I don't think it is necessary to like abandon the way you're doing it. Yeah.
I think also the cause of the leakage is intraluminal tension, not only the tension on the staple line, but also intraluminal tension. So the higher diameter you make, the lower tension you will have according to Laplace law. So I absolutely agree with Dr. Paseka.
I have a question for all members of today. I am Dr. Seo from Korea. And what is your country's state for insurance coverage for bariatric surgery? Recently, 5 years ago, the Korean government decided to start to cover bariatric surgery as a national insurance coverage system. In Korea, we have a very unique insurance system. The national insurance health system have only one company by national insurance health system. So they decided to cover bariatric surgery. After that, the case number of bariatric surgery is increasing now. So I wondered about the what is your country's condition about insurance coverage for bariatric surgery?
Yeah, in Czech Republic.
Oh, sorry.
Okay,
Go
I'll
on.
take I take the answer. Okay, in Czech Republic is fully covered if the patient meets criteria. So because it's proved by IFSO and other organization that is economically reasonable, because the insurance company will save a significant amount of money in future by preventing complications. They decided to cover. So if the patient is fully indicated according to the criteria, it's covered.
In Thailand?
In Thailand, we have the government reimbursement by divide into three. Right now we have a 4 foundation. We have the divide the foundation to make it everything is free for the patient.
I will answer for Malaysia. Malaysia has two types of hospital, the government or the private. As for the private, the insurance are still not covering for bariatric surgery. So some of the patients will probably try to combine it with other surgery like a hiatal hernia or a cholecystectomy, and thus to able to get the insurance to partly pay for the surgery. However, for the extra procedures, the patient themselves will pay. As for the government side, the instruments, the equipments, the staplers are not funded by the government. So at times we ask the patient to pay for themselves, which is much more cheaper than the private hospital. So the patient will probably pay about 1,000 to 1,500 USD.
Okay.
Okay. Do you have any questions? Can I ask you, the Professor Cagas, how you select after the leakage test after you do the surgery? You use the ICG, also use the battery board. So which one is you prefer, and how you collect it? How you select it?
You know, the ICG is rather controversial because you know, we not use it all the time. I normally use ICG only in colorectal anastomosis, in right hemicolectomy, in sigmoid resections, and so on, to be sure that the blood supply is good. In bariatrics, usually the small intestine is very well supplied with blood, and the stomach as well. So I, in fact, used the ICG in about 2 or 3 cases when I really was not sure, and I just wanted to see that the blood flow is good. But the leak test, I do always. I always do leak test in anastomosis in OAGB or in Roux-en-Y. We don't routinely use leak test in sleeves. Yeah. So that's our strategy. As you have seen the numbers, we only had 1 leak in OAGB, and it was not like because of ischemia or but we used earlier such like holding stitches, and the assistant, I think, was like holding it too strongly or made some tension, so it like might have cut off the or torn off the stitch from the stomach, and it later resulted in leakage. But the leakage in OAGB is not that problematic as its sleeve, because you have low pressure system, so there is not that big, because you bypass pylorus. And the gastric juice goes directly into the small intestine. So if you we just performed over suture or over stitching of the defect, which was not ischemic, and gave the patient on parenteral nutrition, and she healed well. But if you had this same problem in sleeve, then it is very, very difficult to treat, I think.
Thank you. Okay, has any answer question?
Can I ask the panel, what are the anticoagulant or DVT prophylaxis that you all prescribe for your patients, since most of the patients are discharged day 2, day 3? Do they go back with DVT prophylaxis anticoagulant, or what is the preference and for the duration?
No, I think me and Dr. Cagas, we use the same strategy. We prescribe low molecular weight heparin injections for the discharge, usually 10 days if no extra risk is added. In patients with Leiden's mutation or any other prothrombogenic condition, you simply prolong it, or even do the every 12-hour administration according to the hematologist if needed. But nothing more has been proved more efficient than early rehabilitation, walking, and return to the normal physical activity. But of course, low molecular weight is administered at least 10 days if no other extra risk is added.
I prefer, I think it's similar, but I prefer, even in those more obese patients, the prolonged prophylaxis. So I opt even for 4 weeks. And I also we start with the prophylaxis day before surgery, so to be sure that the procedure is covered by effective dose. Because if you think about it, there's many risks. Obesity, the patient is usually impaired in mobility, and the patient lies on the operating table for 2 to 3 hours if you do bypass procedure. So I prefer longer prophylaxis to avoid unnecessary thrombosis, and it does not need to be in in cuff. It can be mesenteric thrombosis, anything like that, which could even make problem with the anastomosis and so on. So I prefer longer prophylaxis.
Absolutely, and the administration of the first dose 12 hours before surgery is absolutely crucial. That's for sure.
Korean situation is somewhat different from the westernized people. So actually, the spring conference in this year, we discussed about the prevention of thromboembolism after bariatric surgery. So many Korean surgeons agree that we don't need anti-thromboembolic drug before surgery in the BMI lower than 40 or 45. We only recommend for the over 45 or 50 patient before surgery just one time. And many Korean surgeons agree that we don't need post-operative anti-thromboembolic agent for the obesity patient. We recommend active ambulation in the after bariatric surgery, and anti-embolic stocking, and sequencer compression devices is also sufficient for prevention of thromboembolic disease after bariatric surgery. So this is somewhat different.
That's very, very interesting, but I think it is not only about evidence-based medicine, because if there were clear data that there is no need, so we will not use it, but also about the background of the law environment and so on. And in our condition in Central Europe and maybe in Western countries, basically is the same. If only one case in 1,000 happens to have pulmonary embolism or DVT and go to the court to sue the healthcare provider or a doctor, the doctor will have to pay some amount for being responsible for not giving the prophylactic treatment. So we basically overtreat patients with prophylactic treatment for not being sued in future.
But there is
That is a kind of strategy that is behind evidence-based medicine. It is
and may I short notes to it? Because the problem with DVT is also that it often occurs after the discharge of the patient, and you might not know that you had the DVT because they usually end up in intrinsic medicine department, and you might not know about your complications. So there are also some studies that show no effect of the stockings, so in fact you might also do the surgery with no prophylaxis at all.
The reason why I ask is based on our experience, prophylactic DVT before op somehow increases the risk of bleeding during the op. Probably this is much more seen in Asian population patients. That's why probably there's a difference between Eurasians, Caucasians, and Asian. But we will need a further study to show that whether the risk of bleeding is more with anticoagulant in Asian countries or there's lesser risk of DVT here in our side.
Okay, any questions?
Okay, I'm Asadayus from Thailand. I have a question for all the professor. In your opinion, what is the most important factor for the communication about the thrombosis communication, like water drinking, like BMI or anything else? What is the important factor?
Those risk factors are well described already. I think it's the length of the procedure itself, the position of the patient, and the severity of disease. It also increases with the weight. If you have cancer patient, it has bigger risk, and there is also the estrogenic activity. So high risk have women, and the obesity itself is estrogenic or creates some estrogens. So the obesity is also a risk factor just because of this hormonal activity. So it's the reason to be very cautious.
Okay, thank you for. Thank you for your sharing. Yes.
Right now, I think it's a good time, and thank you everyone for the good topic and sections. Thank you again for the Ezisurg Medical to support us. Thank you. Let's make a It's really close. Thank you, everybody. Take some rest.
Thank you very much.
Thank you.
Goodbye.
Bye.